At DCS, there's usually about 1,300 to 1,500 people at this chiropractic circus convention. And there's always somebody with a few tables out in the concourse, you know. I sometimes adjust people there. I sometimes watch people adjusting their friends and whoever with, you know, hundreds of people milling around yelling and screaming, you know. And so here's the problems that I see watching the adjusters at DCS. You see the whole gamut of skill level, from snail-like recruitment, total beginners, to middle-of-the-road people, to people who will never be good because you can see it's not serious, they don't have any power of concentration and focus, and then you really see some masters out there in the concourse. You see it all at once, you know, it's really interesting. So, you know, it's a funny thing. No, it's not a funny thing at all. It's no coincidence that those with the greatest skill levels are also what? Those who have developed the highest powers of concentration and focus. And they are setting up on a patient and they are about to adjust, and there are not 500 people walking around me. There is no noise. There is no spoon. There is nothing else. There is this subluxation at the present time and my focus on it. That's all there is. And you see that. And intent. Now this is something that I'm only going to spend a couple minutes on. This is kind of like a delineator that separates the perpetual dilettante from the profession, in our profession. Could I really go that far? Yes, I can. I will. Your awareness of this reality will separate the person who is destined to be a dilettante forever in this profession from the true professional. Your understanding of this concept here, or at least your awareness of it. The power of intent. Now remember how I was telling you guys how there were several techniques that I didn't really, you know, for years and years, I didn't really personally approve of because I never studied them, I never understood them. And it's like, and then I would be really surprised when somebody would come up to me, a patient would come up and tell me that their life was saved, they were cured by this esoteric technique that I really didn't understand at all, and I couldn't never understand that. And this is, again, this is the power of an intent. This is the intangible primary component of the highest level of adjustment. Okay, you know the biomechanics, you've made 10,000 adjustments, you know you can do it, you can move this bone, but what is my intent? My intent is to visualize that subluxation already corrected, and to visualize what? The reconnection of universal intelligence with innate intelligence in this person's body. That is not just a bunch of words. That is a physical reality that people who have been in this profession for many years have observed empirically. So this, the idea of the power of intent.
Okay, sit right here and face the class. Say hello, class. All right, tell them what your symptoms are.
I have extreme heavy pain right along this area here. It comes and goes frequently, but this is an episode it's flared up again. So.
Okay, so you guys are going to hear this all day long, every day for the rest of your lives. This exact same thing. Okay, and so you would do an exam, you would take an x-ray, and you would look, and you would find out that she has a T1 on the left. This is the main thing that she has. Now, there's a primary subluxation that you're always going to address, but you're always going to have some secondary things that you're going to find that will be compensation subluxations or compensation fixations that are going to try to adapt to this, because that's what the body does. That's why you have spasm and inflammation. It's the body's way of adapting. So the first thing I'm going to do is I'm going to check the area to see if there's any compensating ones, and then we're going to go right to the money. And this is the T1 that we just kind of been working on. So this is important. So go ahead and lay face down, babe. Okay, so I already know we got a T1 on the left because I worked on her over Thanksgiving when she was down, and so we know what's going on. So I'm going to come down through and check and see. She's got a T6, so we're going to come in just like we've been working on. Now I want to show you guys. I'm going to shut up, and I'm just going to adjust her. and then you can ask questions. So if she comes in, she lays face down. In my office, she's face down.
That was big.
Yeah, it was big. Okay, now, I showed you guys the occiput move. I'm coming under here. C7T1, I open that up. Now sit all the way up, swing this way.
This way?
Yep, sit up tall. Extremities, I'm going to check shoulder here, loose. Okay, AC joint set, hand on the shoulder blade. I'm coming up here, grabbing the elbow, turn your head to the right. Scapula laterally deviates. I'm going to come under the scapula and I'm going to set it, and that's all there is to it. Pulls. Get a rope, like you're doing rope push downs, put it on a lat pull, seated lat pull, grab a hold of it, pull straight back. I guarantee you, you do a ton of those, do like 5 sets of 50. Don't have to go real heavy. That's going to be a piece of cake after a while. You've got to train your body. You guys are chiropractic, truly. At the beginning, I will tell you this, in the beginning, it's manual labor. It just is. As you get better and better and better and better at it, then it becomes more of an art form. And then Dr. Yenny, he was 80 years old, and he would and that was his adjustment. And I sent patients to Kansas City. My CA's father was having some spleen problems. He wasn't producing red blood cells, and they wanted to take a spleen out, and they wanted to do all these crazy things. I'm like, oh, hey, wait a minute, no. Send him to the master. I'm pretty confident in what I'm doing, but there was one person I knew over anyone else. So they drove to Kansas City. When they come back, they told me this story. They said, we left his office, and they said, we didn't think he even touched us. We barely felt anything as far as adjustment-wise. But as we were walking the parking lot, we both stopped and looked at each other like, what's happening to us? Our whole body just started melting. And he said, we laughed and cried all the way home. It was the amazing experience they've ever felt. Intent. When your intent is that powerful, you don't have to do this anymore. I'm not there yet. I'm a lot better. There are times that I am so in tune, I'll put my hands on and you'll feel it drop. You'll feel it drop. Again, this is an adjusting course for you guys who are just getting started. Some of the doctors have been in practice. Well, you know exactly what I'm talking about. When you're in that mode, man, you're on. But for right now, like Tim said, the most important thing, you've got to learn. When I come out of school, I don't know how, I still have some of the patients 20 or 19 years ago, my first patients still come in today. I don't know why. I tried to kill them. I mean, in my mind, that bone was going to move today. You were going to get well today. And I was a big kid. I was, and it was going to move. And I was rough. But through the years, my hand speed, my quickness, my finesse. So you guys, just learn this stuff, okay? So it's really, really important. So do your exercises. Get strong. Take this stuff serious, because you got to remember, the people that are going to get in their car and drive to your office may drive an hour, sometimes 2. I got patients that drive 3 hours one way, and they're in and out of my office in 60 seconds, and they're happy about it. But they get their adjustment. But if you come in and you do that crap to them with the wrong intention, they're going to go, okay, I drove 3 hours for what? Does that make sense? Okay, so any questions about exercises? Train your body, okay? So now we're going to work on occiput, T1, and sacrum. We're going to get, so let's do our first rib. So we have a first rib. Where's she at? There she is. Come on, sis. So we're going to talk about this first rib. You won't see a lot of them because the first ribs are pretty protected. They're under the collarbone, and there's a lot of traps on your tummy first, babe. So you won't see a lot of them. But when you do have one come in your office, you're going to know, and it's debilitating. It's that I can't take a deep breath. I can't work my shoulder. I got pain on this side. A lot of times, it's a brachial. You guys will hear brachial plexus syndrome. You know what the medical approach to this? They cut the first rib out. Brilliant. But you got to get in there and find it. Now it's under the collarbone. So there's 2 different ways of getting it. Which side is yours on, honey? Right side. Can't really get it to move that way. So you've got to come in on the first rib this way, and you're going to set it from the anterior part across. You're going to bring the whole bone up. So you're going to contact, when you get in here, you're going to contact, your thumb is on the rib head, and then your fingers are on C1, and you're going to come through this way. That's one way of adjusting it, over on your back. Pick which one you like. I prefer this one because it's easier on me, my hands are fast this way, and it's easier on the patient too. So she's got first rib, okay? So everybody needs to know, okay, come over here. So here's the collarbone, okay? First rib is sitting, here's the sternum, so it's sitting right under there, okay? And it's going to push in that brachial plexus. It's sore as a boil right there, isn't it? Mm-hmm. How do we know that? Look at her pretty face. Watch what it does. Let's do it again. No. Okay, so what I'm going to do, I'm using my fingertips, okay? Now, I'm going to adjust her like I adjust her. I'm not going to slow it down for teaching because the first ribs suck, and they have to be set right. If not, it's just going to make it worse. So again, everything is gentle here. We're not breaking trees. So we're going to come in here where that first rib is. I'm going to come up underneath of it, and you're going to find it. We're going to fold all the way across it. Right there. I'm really not happy with the adjustment at all. How'd it feel? Fine. Yeah. It moved, but it wasn't. And again, you guys will learn this. This will go back to instinct and feel after doing it. It could be fine, and more than likely, if in my practice, I would leave it alone and tell her to come back tomorrow. Okay, just let her rest, let me rest, get away from it. But I won't see her for a while, so I'm going to go. Okay, so here's the thing. First rib attaches in the sternum, then it attaches to what? T1. Okay, I shouldn't confuse you guys on that one. Okay, so I'm going to go to first thoracic, and what I'm going to do is I'm going to move the articulation, the junction between T1 and the first rib, and it's still not moving.
I didn't like that.
No, it sucked. That sucked bad. You're a bear. All right, so now we pull out Old Faithful, and that moved it a little better. Still not happy with it. On your tummy. You're going to be sore as a bull, and I get no idea. So and actually this is important. I'm glad we have this because this is reality. You guys, this is reality. Not everybody's going to be, click, can I pay you $1,000? It's not going to be that way. So then we're going to come back to Old Faithful. Okay, now sit up. Finally. Probably should have done that in the first place, but I wanted to show you. So there's different ways of attaching it. Now, I'm still not 1,000% happy with it. She's got a real bad area in here, so I would see her 3 times a week for the next 8 weeks, without a doubt, to get this thing corrected. So you need to get adjusted. How often? Okay. But find somebody that knows how to set that, though. I'm trying to think. Yeah, you guys just knocked the snot out of that, okay? All right, we're going to leave that alone, okay? Yeah, she'll get even, exactly. She's ahead of you guys. Okay, any questions about T1 real quick before we move on? Nope? All right, we're going to do occiput. Who's got an occiput that needs to be adjusted?
I want sacrum.
We'll get sacrum. No occiputs? Oh, come on. Come on. Okay, so we've showed you a couple different occiput moves. This is how I adjust the occiput. I think for me, it's more efficient, it's more effective, it's easier. So picture the occiput. We got one somewhere. Here's the occiput. You got occipital condyles. They sit, and then you have the atlas, so they're rocking. It's the saddle joints, right? Okay, so here we go. So it's sitting like this. So basically, the occiput is we're going to move this bone through that plane. All right. So we're basically adjusting the skull, for lack of a better word. But as it's laying here, and you turn, we're going to pick that thing up and we're going to move it. We're going to move it through that facet, right? Okay. So there's a way you can lift it this way, is one way we learned it. But we're going to adjust it, and I'm going to show you guys to adjust it like you would an atlas or anything else. The key to this is line of drive, tension, and hand speed. That's why it's important for you guys to work your hand speed, work at quickness, work at release. I mean, everything in you's got to be, this has to be quick. So we'll, and when you palpate occiput, it's real simple. Just come off the base of the skull, real gentle. You're not digging. It's gentle. Come up underneath here. And those fibers, he's got, there it is. Sore? Mm-hmm. Okay, so the fibers, the occipital fibers right here are just, once I kind of got into it where we're sitting at, it's like real tight banjo strings right there. Okay, so we learned how to either open it this way or this way, but I'm going to show you a different way. Now, patients are going to come in with occipital headaches, are going to come in with sinus problems, are going to come in with migraines. I've even, patients come in with, they think they have gout in the big toe. I'm adjusting occiput. Works every single time. But, so what we're going to do is gentle cup. Now, occiput is here. Your line of drive is almost like this. So you've got to be real specific. Don't get on the atlas. You're lifting, it's still like a lift. You're just lifting it with more velocity and speed and this way. Does that make sense? More of an impulse. So, and all I'm doing with this hand is cupping the head. And, you know, don't jam the thumb in the ear and all that stuff. Right here. Open the head up. Instead of this, open it up under the occiput. Okay? Everybody got that? We're going to set it down. Now I'm coming, look at my angle. Under here, right under, and I'm setting it right there. I'm coming straight through. Now for you guys, what I want you to do is I want you to set up, and I want you to go ahead and I want you to adjust it, but when you set up on it, I want you bring this elbow in, and when you adjust it, just try to get movement in there, okay? Now, he has an atlas over here, so I'm gonna go ahead and adjust it. Come across, right there, okay, up. I know when I show those kind of adjustments, it's hard for you guys to kind of, but that's how I adjust. That's how I want you guys to learn to adjust. It's quick, it's fast, effective, it doesn't hurt at all, does it? My T1, where's my T1 girl at? I'm sure you're gonna argue that. You're just a mess. But let's set up on that real quick. So I want everybody to get hands on the occiput before we move on, because I know some of you guys got to leave early. See 13 or 14-year-olds with menstrual cramps, and they're going to be awful. They're going to keep them home at night or home from school. And then the next thing, so what is the typical treatment plan for that? When they go to their OBs, what do they do to them? Birth control. So now you got hormones are jacked up, but the cause of the menstrual cramp is still there. So the next thing you see, amenorrhea, dysmenorrhea, 18, 19 years old, their cycles last forever or they don't have one. Then the next thing that happens, ovarian cysts. Then the next thing that happens is endometriosis. The next thing that happens is they can't get pregnant, and next thing you know, they're 30 years old having hysterectomies. It's an epidemic. I see it day in and day out, and it starts with menstrual cramp. Whether you want to believe this or not, or know it or not, menstrual cramps are not normal. It's a normal biological process that happens every month for every woman, and it's not supposed to hurt. If it is, why doesn't every single girl during the menstrual cycle have pain? It's supposed to. No, it's not. So when you see these things, or you're going to have a patient that comes in and they're having problems conceiving, or they just have pain. I mean, irregardless, it's the sacrum. 999 times out of 1,000, it is base posterior. It's base posterior, and sometimes well, I shouldn't say that many. You know what? I take that back. 75% of the time it's base posterior. Then we're going to have some that are base anterior, the thing's sticking up. But a lot of times you can just have a patient lay there, and depending on the symptoms, but you can come in here like this, and man, that thing is sticking up. I mean, it's just sitting like this. Now, so, and males get it too, more than females, because of high heels and baby giving birth. Oh my gosh, that's awful. It'll throw the sacrum off. Having babies is horrible on the sacrum. And the males, I'll come in here and just set it. Not on my girls. Again, I'm going to show you the side posture. So let me get this stupid thing over here. Okay, lay on. Now here's the thing. If it's base posterior, then we're going to adjust the whole sacrum. We're going to adjust it P to A, the whole top. So it really doesn't matter left or right side. It's whatever you're most comfortable with. I'm most comfortable over here. So I'm going to have her lay on her right side and turn to face me. Again, always keeping your hand. I'm always got my hand on my patients, always. Okay, pull them off the shoulder, hand on the elbow, okay, and then relax. And so when they're all doing this, just relax, okay? Straighten the bottom one, bring the top one up. Okay, now, really important, again, I'm not going to do it again, but let them know you're not going to drop them. Keep close with them. So we're going to come way over here, okay? Come way over here. Now, she's got a really pronounced posterior. So, guys and girls, I mean, everybody should do this, so just get in habit. You will say, I'm going to have to get on top of this. This is going to be a little weird. Let them know that you're getting ready to grope them, kind of. So, you can come through here, which is fine, but really, if you're going to get a good adjustment, you need that skin contact, because this is a tough adjustment. So again, I'm bringing her all the way over where the sacrum now is right there, okay? So I'm going to come right in on top of it. Now, we're going P to A, right? Posterior to anterior. So I'm tractioning. Now, when I do this, I'm not out here. I'm not falling on her. I'm not doing this crap. I'm in here. But my thigh on her thigh, I'm tractioning with it. Tractioning here. I'm not letting her fall this way. I'm keeping her up here. We're going to come right to this, on top of it, and set it. Okay? Everybody see that? Okay. Move good, didn't it? Mm-hmm. Okay. Set it all the way up. All right. Questions about that before we move on? Okay. Any questions about it? Okay. Does anybody else have? I'm going to show you. I'm going to show you the posterior, and then I'm going to show you the other one too, so you can see both sides of it. Wait, help that, babe. I need another girl. Come over here. Okay. Now, go ahead and lay on your tummy. So again, I'm going to show you from the front. So you're going to go in. Now let's say on this one, we've got a sacrum that's base anterior, and the tailbone is sticking up. And I mean, you can kind of get up here, and I mean the tailbone's like the coccyx, like right there. I mean, you have to kind of get down in here. And here's the thing: when they hurt, I don't care what you do. And I'll tell patients, okay, I don't care where you put your hand, just fix this damn thing. Still, be real cautious to this. Here's the thing: my uncle was a chiropractor for 30 years. He never carried malpractice insurance. That was back before you had to have it. He in his mind, if I carry malpractice insurance, it's just because I don't trust myself. I know what I'm doing. They know what I'm doing, and he never had a problem ever. I mean, and I've seen him do some crazy things. So, but it's about your intent. As long as you're going and doing, they know. You don't worry. I know they teach you this stuff in school. You're going to get sued if you touch their butt. Whatever. Just you're helping them. So lay on your side. Now on this one, I'm not going under the pants on this one, because what we've got to do here is, and this will be kind of weird. So we're going to come here. Now you're going to come under. So if you remember your anatomy, we got the sacrum, we got the hips, we got PI, you got your SI joints, you got the top and the bottom one, right? So what I'm going to do is I'm going to get right under between the bottom SI and the sacrum, and I'm going to adjust this ilium, this SI, off that sacrum. I'm going to take the pressure off this area, and that's going to allow this to come back. Does that make sense? Can you guys picture that? So, but what you have to do is you have to come up under the butt cheek here. You got to come underneath of it until you get right there to it, all the way over, same thing, and set it. Beautiful, all the way up. Okay, you're opening it. Yeah.
So what was your contact on that?
My contact. Oh yeah, that'll work. Okay, my contact is right here. Here's the butt cheek. You got to come in here, and you got to get right there. See, this thing went this direction. So when I adjust here, it allows, when this comes this way, this comes back. This has come this direction, so it's holding it. So when I set this joint, and a lot of times I will do bilateral. If that whole sacrum is dropped, I'll do it both sides. I'll set both sides. And I have this a lot with pregnant patients. And you can adjust a pregnant patient just like that. I don't care if they got disc. I've got patients who have Harrington rods all the way to L4, and I adjust those hips like that. Don't tell them you can't do it. This is stupid. Yes, you can. So what I'm doing is I'm tractioning, and I'm coming under here, and I'm adjusting that bone. Does that make sense? God, it's nice to have a spine in it. Okay, any questions about that? Okay, let's set up on them. Basically, on the prone technique on cervical, what I do here is we're coming through, and it's P to A, depending on if it's left or right. Let's say it's left or right axis. Let's go C2, because that's, That's what he has. He has a C2 left. So I'm gonna adjust it prone this direction. So what I'm doing is I'm tractioning here. My thumb and my forefinger are my contacts. And I'm going to come through and set it. And that's really all there is to it. Now, this is where I'm different. I didn't like it. It didn't move worth a darn. So, a lot of my patients, I can do that, and it sounds like the whole world just came to me. It's like, boom. I mean, it's huge. I got a bunch of them. They lay face down, I adjust them, and they're out the door. That's all I do. That's all they get. And I mean, they're coming in with all kinds of crazy things. I got one old man, he comes in with he was limping. Adjusted C5 that way, 6th visit, he quits limping. Now go tell your instructors that never mind, on your back. C5, it's no different than the occiput or the atlas or anything else I got to show you. Everything is exactly the same. T1, it's all the same. What's the only difference from T1 to occiput? What's the only difference? Line of drive. But everything else is the same. So if he's got C2, I'm adjusting C2. If he's got C5, so C2 is this way, C5 is this way, T1 is this way, so C2 is this way, C5 is this way, T1 is this way, so C2 is this way, C5 is this way, T1 is this way. So that's the only difference is that's why I'm telling you guys, you have got to study and understand that spine. That's why I told my daughter, she's like, she's whining and crying to my wife that, I don't know how to adjust. You ain't supposed to know how to adjust. I'm not teaching you how to adjust until you've at least had a freaking anatomy class. I'm going to teach her to just do something like a monkey trick with her hands, and then you're going to say, what did you just do? That's really what happens. So study this. So again, let's go down here, C5. Okay, here's 5th cervical. Okay, 5th cervical. If you look at the facet of the 5th cervical, look at the direct line of drive it is. I'm going to do the same thing. I'm just going to adjust it. It's no different. It's all the same. You'll see people and they'll do this thumb move, and there's all kinds of different variations to it. I personally think this. Do the technique that is the most effective, that causes the least amount of discomfort to your patient. I've got a friend that does this, and I freaking hate it. Hurts like, you know what? Hate it. He gets it to move, and I get a little bit relief, but if I was a patient, I wouldn't go back. And there's a reason he's practicing longer than me, and I see more by noon on Monday than he does all week. It's not that he's not a great chiropractor. He's painful. No one likes that. So it's really, really important that all these little things that we're showing you guys, foot placement, hand placement, relax your hands, relax your fingers, get in there. Know your line of drives. Know your line of drives. Just know them. And it's not hard. All you have to do is get a dry spine, lay it on a table, look at it, picture it in your mind, understand it. There's only 7 of them. I mean, it's not that hard. Well, actually 6 because the occiput don't count. Atlas goes side to side. That's real damn easy. Axis goes side to side. So what do you got? What's that left? It's not that hard. Then you get to T1, T2, and then everything else is different. Does that make sense? It's really not that hard. The key is taking the time and really visualizing. Gonstead, what was his famous quote? Be one with the bone. Be one with the bone. He would have a patient sitting in a chair staring out a window in a room. He would walk in behind him, set it, and walk out of the room. Saw thousands and thousands a week. That's all he did. He was one with the bone. Same thing. One with the bone. Okay? Does that make sense? Does that answer your question on cervicals? Who asked it?
Actually spend time like locking out on cervicals.
I'm sorry, honey?
Like do you lock out?
Yeah. Yeah, here's the deal. When you go to adjust, in play. In play is very, very important. No matter if it's lumbar, thoracic, cervical, don't adjust from out here. See, you'll see me adjust somebody and I adjust them. But I'm getting to the in play real quick. Where you guys have to feel that and take your time. Relax all this. Come in here, in play. See? Don't come back. Because that's what jams that tissue. The worst adjustment I ever got in my life was a clinician at Cleveland. years ago, and he did a lateral break on my neck. And he come in here just like this and just jammed my head sideways, just jammed my neck sideways. I thought I was going to go paralyzed from the neck down. It was awful. And this was a clinician. It was awful. And I never forgot it. Relax. Come in play, set. Right now, you're not doing that. Right now, set. You're going to start out like this, then it's going to get a little quicker, then it's going to get a little quicker, then it's going to get a little quicker. But eventually, they're going to lay face down. You're going to set them up, and you're going to move. Does that make sense? Set. You're going to start out like this, then it's going to get a little quicker, then it's going to get a little quicker, then it's going to get a little quicker. But eventually, they're going to lay face down. You're going to set them up, and you're going to move. Does that make sense? Set. You're going to start out like this, then it's going to get a little quicker, then it's going to get a little quicker, then it's going to get a little quicker. But eventually, they're going to lay face down. You're going to set them up, and you're going to move. Does that make sense? Questions about that? In play is important. On your stomach real quick. No different than what we're trying to set up here. A lot of you guys were coming around like this. Well, here's what I saw a lot of. You know, in which, you know what, we're giving you a hard time. You're supposed to do that. You guys are supposed to do that. Cup it under, traction it out. In play, not this. In play, drop, drop, drop. Just learn. But you guys, I'm telling you, is everybody here in the philosophy club? Raise your hand if you're in the philosophy club. Oh, shame on you guys. I want everybody here going to every philosophy club meeting. And everybody else, you make sure to let me know. You guys will spend all this time in all these other classes, and I know you have to because you're paying for it, but you spend all this time that is absolutely not going to help you be a better chiropractor, and yet the philosophy clubs, what your true essence of what you do, that's going to make you a better chiropractor and you don't go. This is going to make you a better chiropractor. So you guys get to somebody's house, go to Richard Snow's, if you guys know Richard, go somewhere, take your portable tables and just get hands on. Start palpating, start finding T7, feel T8, go down the spinous process, spend time feeling the spinuses, feel time, take your fingers, go through here, down through the paraspinals. Give me that spine real quick. Thank you. Take your time, take this thing here, lay it on each other, and look at it, and think about it for a second. Okay, think about what we're doing. So you got all these muscles and all these tendons, and you got all these nerves that you're affecting. But right now, what we're trying to do is figure out if this bone's on that nerve, how do I get it off that nerve? Which brings me to this real fast. I got to say this because I don't want to forget it. There's lots of different techniques. There's lots of different ideologies. There's a lot of different types of practices. There's a lot of stuff in chiropractic. I will tell you in my practice and in Tim's practice and the most successful chiropractors that I personally know, and I know the biggest guys in the world that see the most patients, the most successful, those guys, the most successful practices, all boil it down to pure, simple chiropractic. Here's simple chiropractic. There is a bone on a nerve, and that nerve, whatever's on that nerve, whatever that nerve controls, it's causing problems. Plain and simple. It's the old Merrick system. Whenever someone says, I don't want to run a subluxation-based chiropractic office, my first instinct is to say, well, then you're not running a chiropractic office. You're running a physical therapy office, you're running a personal training office, you're running a nutritional office, but chiropractic is a bone on a nerve causing disruption. Plain and simple. It could be disrupting the nervous system, it could be which stresses the immune system, which causes immune systems like allergies, whatever it is. So take your time and look at this and pay attention to this. So what I'm doing is, when I'm going through here, I'm feeling these. This is your livelihood. I'm just feeling them. So as I'm going through here, I'm feeling those. I'm feeling them. I'm feeling them. Feel what they feel like. And what's going to happen is you're going to do this, and you're going to go through there. And I use this analogy. Patients sometimes say, what are you feeling for? And I said, okay, let's say I take a sheet, like a bed sheet, and I throw it over a 2x4 between two sawhorses. You guys visualize that? So we have a 2x4, a real hard 2x4. There's a sheet over it. You don't see just a sheet. And I'm pushing on that. Okay, I'm pushing on it. Let me switch it. I've got a piece of plywood, a real thin piece of plywood between two horses. And as I'm pushing on it, you can feel that plywood give. Along the line somewhere, there's a 2x4. Okay, give, 2 before. Does that make sense? So as I'm going through here, I'm feeling these, and I'm picturing in my mind, lay the spine up on them until you guys get this burned in your brains. Look at it. Okay, T7, that's what it looks like. Here's what the TVP looks like. That's what it feels like. So as you're going through here, you're going to feel them. It feels good, feels the same. Don't know what I'm feeling. This feels like wait a minute. That doesn't feel like that. Then you're going to say, what's that feel like? Hurts like hell. Ding, ding, ding. Where am I at? Okay, count it down. I'm at T11. What does T11 supply? What nerve supply? Where does that go? Small intestine, large intestine, you know, whatever it may be. I actually, believe it or not, I have a chart on my where I can see it. So there are times that I'll stop I'll stop and look at that chart, and then let's say it's gallbladder or liver or whatever it is. That's what I think about. I think about their liver. Okay, it's not functioning appropriately. What I'm going to do is I'm going to release innate back into that liver. That liver's taking a great big deep breath and saying thank you. And I see that. I know it's weird. Be weird. You're chiropractors. Does this all make sense? Whether it's cervicals, sacrum, hips, these are all just moves to do the same thing. Free up those joints, restore proper motion, take the stress off the nervous system, allow the body to come back to proper tone, proper health. Sit all the way up. Okay, any questions about that? Lots and lots of fun. What we've talking about at lunch a little bit, or I talked about earlier, here's what's interesting. The only people that understand it and get it are your patients. Other practitioners, everybody else, I got more medical doctors and dentists coming in than anybody. Everybody gets it except for our own damn profession. They want to make it complicated because it's not complicated. Okay, it's just not. It's so simple. Adjust and get the hell out of the way. Okay? All right. Practice. The way they used to do in the old days, and this is really a cool thing too, they should have some even at school, but you guys can make them. Go get a car tire and cut it and nail it one side or the other down on a board where it's like humped up here and drop through that. You guys got one?
Actually, what I'm referring to is more the leg drop.
It's just, again, practice. Practice. You know, it's just like anything else. If you're going to kick a football, you better practice kicking that damn football. If you're going to throw it, if you're going to drop, just get up on a table, set up, picture. This is, you guys, how you practice. Okay? Let's say here, you got a tough one. I see it. You got a T1. Just practice. It's just repetitive. It's just repetitive. And here's the thing. It is strength, it is force, but more and more it becomes accuracy. Again, I love Bruce Lee. I mean, good Lord, since I was able to watch TV, he has been my hero. But you watch, look how little, he only weighed 130 pounds. 130 pounds. But his accuracy and speed was so freaking ridiculous that he could overcome anybody with accuracy. That's why, my girls, you guys, it doesn't matter how big you are. You learn to master that intent, that adjustment, and I promise you, you can set anything that you want to. You can. I've seen it. I've seen the littlest girls freaking rock and roll. They can do it.
How do you adapt to someone who has like a scoliosis?
Oh, that's a good question. You got a patient that comes in, and I've got a ton of them. They're like that. I got a lot of them. You look at that x-ray, and that's, again, when they tell you that you shouldn't take x-ray to detect that, raise your hand and say, well, what if they've got a 23-degree scoliosis in the lumbars and you can't see it? Deer in the headlights. So, okay, so what you do is, again, what you're going to do is, if the spine looks like this and it's rotated this way and it's causing pressure, what is your most common sense approach? Bring it back this way, right? So I'm going to get in here and I'm going to adjust back this way. Look at it, analyze it, picture it, decide what you're going to do with it, then go do it. And don't adjust them 4 or 5 times and refer them. My scoliosis patients that come in like this, let's say they're 17 years old and I get this, I will see you 3 times a week for the next 6 months if I have to, or the next year, or the next 2 years, the next 5 years. It doesn't matter. Because if you ever have a child come in and they've got Harrington rust from here to here, it'll turn your stomach. And go watch one of those surgeries. Go watch a surgery and then see if you have a problem telling your patients how many times you need to see them. Take this stuff serious. And don't be afraid. Does that make sense, George?
Do you ever have limits on side posture for, again, disc protrusions or
Nope. Nope.
severe ones?
Nope. I have some of the worst discs you ever see. They're getting on their side. I'm tractioning them over. I'm getting on it, and I'm setting the damn thing. Because what's going to fix it? What's going to fix it? What's going to fix it? The adjustment. How else are you going to adjust it? Horseshit. If you don't get in there, if that disc, think about a bad disc. You got this big old bulging disc, and you got 2 lumbars cramming down on it. How much tension or pressure is in there? And think about every time they take a step, or every time they sit down, or every time they pick up a hay bale, or whatever they're doing. Think about how much stress is on it, and you think you're going to hurt it? If stress caused it, what's going to correct it? If force caused it, what's going to correct it? Do not be afraid. Do not be afraid. I've got patients that come in with cervical discs that are bulging. They've got C3, C4 have a plate, screws in it. Cervical disc on C3, cervical disc on C2. And they've been to their neurosurgeon, they're scheduling surgery, and they want to come into me. What would you guys do? 2 cervical disc bulges and a plate in the neck. What would you guys do?
Call you.
What are you taught to do? No. What are you all taught to do? Refer. And 99% of the population will. When Dr. Gibson is going to come and talk to you guys the next philosophy class, the next club, ask him about his patient. Tell him to tell the story about the patient with all the cervical hardware in her neck and how he adjusted her. Have him tell you that story. I would lay this patient on their backs. I would come above where the plate is, and I'll tell you this, I've had cervical fusions that I'll just, C3, C4, I'll adjust both bones just like one bone. I'll set the whole damn thing. I'll get in here and I will set that cervical and I will move the bone off that disc, because that's what chiropractic is. I don't have no fear adjusting anybody. I just don't. You guys are learning, so you're going to, but get over it. Get over it. The faster you remove your fear, the quicker you're going to be successful, okay? Doesn't matter what they have, adjust them. Adjust them. Quit listening to the ones that failed in practice tell you that you're going to hurt somebody because you're not, okay? All right, any more questions? Okay, extremities. What do we want first? Wrist? Okay, come up here and sit. Okay, here's the thing about extremities. I will highly recommend you all do this. Find a Mitch Malley, M-A-L-L-E-Y, seminar and go take it. This is where I learned this stuff. He is a master at it. And what he will do is he will spend a whole day not only teaching you how to adjust it, but he'll give you the anatomy, the physiology, all the stuff. Swing over this way. I want them to, well, hang on a second. I'm trying to figure out how to show them. I guess we could do it this way. Okay, so here's probably the number one injury you're going to see to the wrist is a lunate subluxation. Anybody know what the lunate is?
Yeah.
It's a little round bone right there. So this is what causes true carpal tunnel. Now here's something too. Carpal tunnel is numbness or pain in the thumb, the finger, and half of this finger. If it's anything else, it's not carpal tunnel. Pretty simple, isn't it? Median nerve is carpal tunnel. If it's all 5 fingers, it can't be median nerve, can it? Because the median nerve doesn't supply the pinky. So then you're looking at elbow, shoulder, or neck. Most of the time it's neck. But if it is this, or if they're having wrist pain or wrist problems, then what we're going to do is we're going to adjust the lunate. The lunate will drop this direction, so it's actually, this is anatomical position, so it drops superior. I look at it this way because that's how we walk. So it drops down. So if the lunate drops down and we do this between the lunate and the tendon here, there's the median nerve. So that bone is pressing on that nerve, right? Okay, does that make sense? So what we're going to do is we're going to pick this lunate up, and you've got to picture, when you study the anatomy of the wrist, you'll picture picking the lunate, the bone up, and setting it on a shelf. Okay, that's what I see in my mind. If you have does anybody ever have a quarter? There's one laying over there on the deal. Somebody grab me a quarter. I want to show you something. Okay, here's a quarter. So here's what we did to practice this. Take a quarter, and do that. Put them between your fingers. So that's how fast your fingers are going to move, okay? So what I'm doing is I'm taking my index fingers, I'm coming under the lunate. The rest of my fingers are opening up here. My thumbs are over the top of the lunate on this other side. I'm going to lift it, and when I lift it, I'm going to take my thumbs and I'm going to set it in place. Does that make sense? And it looks just like this. You got to get them relaxed. Just like it looks just like this. You got to get them relaxed. Just like it looks just like this. You got to get them relaxed. Just like that.
That wasn't the broken one. I'm just kidding.
It is now. And right there. Now this is something I want to tell you. See, her hands are just sweating like crazy now. I will tell you something funny about this. There are thousands of parasympathetic nerves in these wrists. I've had grown men, after I adjust them, break down and start crying, just dumping emotions. You'll have women just almost lose it sometimes. And if that happens, you just hang on to them for a second. Be calm, don't panic. They'll come back. It's a dump of emotion. It's crazy. Okay, all right, want to do this other one?
And would you do anything different with a plate in it?
Okay, now she's got a plate in her wrist, so yes, we do it different. Okay, remind me where the plate goes.
So it's
Okay, so it's up in the bone. So okay, so the carpals are below it, but you're still going to have to be a little bit more careful, so you don't want to jam them. But at the same time, she needs it because now her carpals are having to work extra hard to try to overcompensate. So now, learn the bones of the wrist. You got scaphoid, you got the lunate, you got the triquetrum, you got all these different bones. So, but you'll learn, just like you did everything else, you'll learn fixations. And she's got a whole bunch of them. So this is the scaphoid bone, and it's a big square bone over here. So I'm going to take my fingers and I'm going to pull over here, so you can almost see it come up. See it? You guys see that? I'm going to pull it, and so I'm going to set it, not kind of on the shelf, but I'm going to set it over a little bit. It's a bear. Yeah, it's on the shelf, but I'm going to set it over a little bit. On the shelf, but I'm going to set it over a little bit. On the shelf, but I'm going to set it over a little bit. It's got scar tissue in there. It's got a scar tissue. So I got a little movement in it, and sometimes you'll get a little movement. There it goes. And then I don't know why I do this. This is one of those things, I don't know why I do it. I just do, and it's always awesome. I always come in here, take the pressure off that thumb joint. After every, it just takes all the stress off your wrists and hands. It feels good. People just love it.
How do you do that?
Well, okay.
Just do it.
Anybody else want wrist adjust?
He has a wrist problem.
Who does? Oh, get up here. Well, I'll get everybody before we all leave. And then we're going to have to move on to the next. But I want to show you this, and then, what time is it? 4:50. Okay, we got some time. Okay, so wrist again. Here's what we're doing with the wrist. You're gonna palpate. You gotta spend time kind of learning what you're palpating. And see, she's got a lot of laxity in there.
From volleyball.
Yeah. Okay. Now, here's one. So we'll just go right on the elbow. Turn the arm over. Ulna, radius. The ulna articulates down here with the wrist. The radius articulates over here. Saddle joint, saddle joint. So when we turn our wrist over, bones cross, right? Okay, so a lot of times you may feel these restrictions in the wrist, but if the bone here rotates this direction from doing certain things, you're twisting. A lot of carpenters that use screwdrivers, you'll see this a lot. Tennis players, tennis elbow, blah, blah, blah. The ulna it'll turn. Well, it's one bone. So if it turns here, it has to turn down here, right? But I'm trying to adjust it here. It's really not the wrist's fault. It's this ulna. So then what you do is you come under the ulna here, and you have to be really careful with these. The ulnar notch, where the funny bone, the nerve, the ulnar nerve. So you're going to come under it here, and you set it. You're going to come under it here, and you set it. You're going to come under it here, and you set it. Oh, that felt good, huh? Okay, now, if you're going to adjust the radius, the radial head's a little different. if you look at the anatomy, stand up for me for a minute, sis. So what you're going to do with it is you're going to turn this way. You're going to adjust. You're going to come. The radial head's here. Hold the wrist. Turn it so it's open. Okay. And we're gonna get right underneath that radial head, and we're going to come up. That. And we're gonna get right underneath that radial head, and we're going to come up. That. And we're gonna get right underneath that radial head, and we're going to come up. That way. Now she didn't really have, that's not her issue. Her issue was the ulna. But if you have those, you kind of, a little bit of a snap and up, not in, it's up. And man, that thing will pop. And again, you'll see people just, flounder all over the place and hang on to them. They'll fall on the floor.